Georgetown for the past year and a half now, and we've used this as an opportunity to have a holding space for topics as broad as the topic of early childhood is, and being responsive to the work that's happening in the field, across the many disciplines that touch and hold young kids and families. For this reason, we are so pleased today to be hosting Dr. Mary Margaret Gleason and Lindsay Estrie, both from 0 to 3, to talk about this new world of telehealth that we are all catapulted into, perhaps a little bit behind our other mental health colleagues that have been doing it a bit more with older kids before this time. But we are excited to have this as a platform to talk with you all about how to engage and support families within this platform. A little bit about our learning community, and we will be sending some follow-up to this conversation. But this, as I said, the topics have been intended to be broad, really supported by the TA Network, which is funded through SAMHSA, to support the broad service array of early intervention and prevention-focused early childhood providers, as well as more deeply clinical ones. And we are holding this as a space. This is the last slide deck that you'll see from us for this hour. The rest of it will really be in conversation format. We want this to be an opportunity for you guys to ask questions of these experts that we have here, and talk together about what you're seeing with respect to the needs in your communities and the families that you serve, and the workforce that we're all trying to support as well during this time. And so we will be watching the chat, monitoring it quickly. We have a bunch of backup eyes in order to help us do that. And we'll be also sending out some additional resources after this closes with respect to some themes that either didn't get fully addressed or that we're able to send some more details about after that. I'm gonna stop sharing and just take a minute to introduce our two panelists. So Lindsay Estrie is the Director of Infant and Early Childhood Mental Health at 0 to 3, where she guides their national policy agenda and leads related technical assistance projects and collaborations working at the state and federal level to increase access to and utilization of high quality mental health services for young children and their caregivers. She was formerly serving as the Director of Special Projects at the Institute for IECMH at Tulane University School of Medicine, where she was on faculty. Her work is focused primarily on the translation and dissemination of research in the field of infant and early childhood mental health and development to inform policy and program decisions. She received a BS in neuroscience from College of William & Mary and a master's in public health from Tulane University. She's currently a member of the Maryland, DC Association of Infant Mental Health and formerly sat on Louisiana Governor's Children's Cabinet's Advisory Board. Dr. Mary Margaret Gleason is a pediatrician and child adolescent psychiatrist. She serves as the Division Director of Child and Adolescent Psychiatry at Eastern Virginia Medical School and the Vice Chief of Mental Health at Children's Hospital of King's Daughters. Her practice specializes in the mental health and care of young children and their families, especially in non-mental health settings. She has worked closely with state public health leaders to develop federally funded programs that offer mental health consultation to pediatric clinicians, early interventionists, and perinatal health care clinicians. Dr. Gleason partners with those at the national level, including 0 to 3, the American Academy of Pediatrics, and the American Academy of Child and Adolescent Psychiatry, working closely with each of these organizations to promote best practices for young children. She participated in the diagnostic criteria 0 to 5 with 0 to 3's work group and co-led 0 to 3's infant and early childhood mental health work group. So with that, I hand this over to the very capable hands of Lindsay and Dr. Gleason.
Hey, thanks so much for having us. We're really, I think, excited about this conversation. This is something Mary Margaret and I think really enjoyed connecting about. So I'm gonna essentially pose a bunch of questions to Dr. Gleason, and then we'll hear what she has to say. And then, Kate and I can add some commentary throughout where we see the fit for that. So hi, Mary Margaret. First, I think we wanted to just talk, I think both to give the audience a sense of kind of what your perspective has been on this, and then to hear some of your initial thinking I think it's really valuable to point out that given the nature of your work and your recent transition to Virginia, that when COVID hit, you were really supporting clinicians in 2 different states, and you were seeing how that conversion to full telehealth across multiple hospitals, clinics, mental health consultation programs. So I think you had a really broad perspective. And I'm wondering, what were some of your initial observations about how clinicians navigated that?
Absolutely. And first, I just want to say thank you for including me in this conversation. It's really exciting to be part of the world of infant and early childhood mental health, thinking about how we navigate this new world in COVID. And so I appreciate the chance to share my experiences and look forward to hearing what other people think in the Q&A section. So as you said, I was part-time working in Louisiana, part-time here in Virginia when COVID hit, and really did have a chance to watch transformation of care in 2 different models. I think a couple of things that were universal, or at least across the 2 states. First is that at the end of the day, the bottom line is all of the clinicians that I work with are heroes, and really moved from a very in-person approach to care to telehealth remarkably quickly. What we saw in both of the settings that I have the chance to work in was change is hard. Right? People had to overhaul everything they knew about providing infant and early childhood mental health care to children and families. And beyond the microcosm of the work we do, everything was changing outside of work as well. And so it was bumpy, and really took a lot of energy for people to maintain the grace to be present for families. I think that the learning curve was incredibly steep. And for all of us, including me, and I've been doing telehealth since 2005, there were a lot of moments where I felt uncertain. I lacked my confidence in the clinical skills because I couldn't do things like connect with people by Zoom, and it doesn't feel great all the time. And what really happened was it was easy to lose track of what we really know to be the core of infant and early childhood mental health, which isn't about where we are physically, it's about how we are emotionally and in our relationships with the families. And I think that it took some reminding for all of us to keep track of and return to our groundedness of the skills that we have and the ability to connect.
Thanks. So before we get into some of the kind of practice details, I know that you have been, you just said you've been doing telehealth since 2005. I know you've been a strong believer in the promise that telehealth for infant mental health long before COVID pushed us here. So I'm wondering, what are some of the benefits and opportunities that you see to bringing telehealth into infant mental health practice?
So some of the things that I've had the chance to see, and I hope other people have had a chance to experience this as well, is the incredible opportunity that we have when we do home visits or when we enter someone's home by telehealth. We get to see what the home looks like, the natural environment that a child and family live in. We get to meet people who wouldn't necessarily come to an office, but are sitting in the living room and will chime in and share observations, or we'll be able to see how that person and that child interact and what their relationship looks like. I've had the chance to meet other providers because we've been able to invite childcare professionals and other clinicians into our telesessions, which has really been tremendous. And I think that there's an access benefit and also an access challenge. The access benefit is that people who struggle with transportation in our concrete office-based model don't have to struggle with that. The flip side is that across the United States, we have broadband access disparities. And so not everyone is able to access the telehealth services because they don't have access to broadband or a device that will connect. We've had a chance here at Children's Hospital of the King's Daughters to do a survey with the families who participated in telehealth, actually across all ages, not just infant and early childhood mental health. And what we see is that parents are really grateful for this opportunity to connect in ways that don't create burdens of time don't create burdens of transportation, and allow them to have the other children doing natural things at home. So I see that we can really maximize our connections with families by joining them in their real world settings. The other thing I forgot to mention is that other caregivers can join, not just other professionals, but I've had fathers on their lunch break sitting in a truck joining a telehealth session. And the chance for them to come is impossible when we do office-based visits, but was really valuable to have the input and see the interactions among the whole family.
I think that's a great point about people actually being able to join from different locations too. I mean, we've talked about people in the same space who might not always make it to a visit, but that's a really good point. So I think now we can get into kind of talking about the how, how are you doing practice? How are you seeing other clinicians have success? And I'm hoping that in our conversation, we can kind of touch on how you kind of approach and initiate work with families, as well as how you do assessment, how you think about diagnosis and treatment. So in terms of kind of bringing new families in or transitioning existing relationships into tele, we know that relationships are the key to everything in infant mental health. So how do you see telehealth impacting that relationship-based work?
I think it's certainly easier when, to conceptualize as someone who's practiced primarily in office or in-home visits. It's much easier to conceptualize how do we transition a relationship from an in-person relationship to a telehealth visit. It does take additional navigation, or as we talk about in infant mental health, a little bit more of that dance to learn the timing of telehealth. In the beginning, I and other colleagues that I work with found ourselves interrupting people far more than we ever do in real life. But for the most part, we're able to walk people through the technical aspects of telehealth and maintain that relationship fairly easily. For people who are new, the relationship takes more building. This is or was a novel way of interacting with people, and certainly a novel way of interacting in a clinical setting. And so families need to have a great orientation ahead of time so that they, as they face this steep learning curve, begin the visit not flustered, begin the visit feeling confident that they had connected at the right time in the right way, that it hadn't been overly frustrating or challenging. And we want to make sure that they do feel oriented in the same way that we would when we give people directions to come to our office. We want to say, go up the stairs, turn at the whatever we have, the bears or the colored road maps in a hospital. But we want to give people good directions. And ideally give them written instructions, because we all do better with that than the verbal kind. We often in our first visits will need to connect with people by phone first and then walk them through, this is how you connect. And then once we're connected, I think what we've found is spending a little bit more time on the ice-breaking part of the beginning of a visit, connecting about things that have nothing to do with the clinical aspects, but are really more about investing in the relationship, commiserating on the challenges of connecting by Zoom or another platform, asking about what we are seeing in their home, commenting on a decoration or a comfortable chair or something like that. Really trying to help people feel comfortable getting in the rhythm of this way of connecting, and then begin the more clinically focused parts of the visit.
Great. I think that's really helpful. As a parent who has certainly arrived flustered at offices I found hard to find, I love the idea of all the advanced support to families. That makes a lot of sense. So once you've gotten a family in and you've established the relationship, how are you approaching assessment? What about your assessment process looks different in a telehealth setting than it did in person?
I think what we've been conceptualizing is we want to do the same things, but we may end up doing them in different orders and may end up doing things relying on different proportions of the different modalities that we use to collect information. I saw a family for the first time this morning and with one of the residents we have here, and was talking about the fact that in this visit, I spent far more time just focused on the parent because she was on a phone. She was walking around the house a little bit. We didn't really have a view of the dyad. And in investing in the relationship, I chose not to ask her to reorient how she was using her phone, but started with, tell me about your child, and we'll get to the observations. In an in-office visit, I would have been able to see both of them and been able to watch observations and interactions more easily. So I've postponed my observations of the parent-child interaction, both the formal ones and the informal ones, to next week. Just a matter of reorganizing based on what information we have access to in the moment and how to preserve and strengthen the relationship. Our system has not quite mastered really efficient ways of getting paper and what we used to call paper and pencil measures collected. So we're not able to have as much information ahead of time in a visit as we might when we were having people come in and we would hand them a physical clipboard and they would write things down. So we're still balancing that. And I'm finding I'm spending more time on an assessment, taking the history, because I don't have that efficient way of getting information on the paper and pencil measures that I did in the in-office visits. So those are some of the mechanical pieces, just organizing those. In terms of some of the more clinical issues, one issue is confidentiality. And again, this visit I had this morning was a great example. I asked the mother who was there, and she told me herself and the 3-year-old little girl. And partway through the visit, she was talking to someone. And it turned out the child's godmother was there and had great information, was really contributing to the history taking, but I didn't know she was there. And so that's an important piece of telehealth, is recognizing that no matter what we've asked, we may not know who's in the room. In this case, that was a supportive member of the caregiving community. In other families, it may be someone who is not a safe relationship, a controlling or violent partner may be in the room. And so we need to be aware that some answers that we get from the history and some observations may be shaped by people we can't see. I think that's one of the big ones that we look at. And then the other thing that I think most people think about a lot, and is truly a challenge, is for some children, it is incredibly natural these days to talk to a phone, to talk to a tablet, to talk to a laptop, to talk to a TV. And they're willing to do it and they're comfortable and they've been doing it a lot. For other children, this is really uncomfortable. They may have social anxiety. They may developmentally not be at a place where talking to a screen makes any sense to them at all. And so we have to use new tools. And I would argue not necessarily more tools, but we're all learning new ways of engaging children through the screen. So I have, for example, Mr. Potato Head sits next to me and he does some good dances. And when I'm working from home, my dog becomes part of the session, and he can be a positive reinforcer that people get to see the dog when they tell me about their feelings. So there are, I think I'm expanding my repertoire of engagement skills in the same way I did when I started out as a clinician. And I think probably everyone else is too. We need to be much more aware of facial expressions. We need to be more aware of angles and what our face may look like. I've become, unfortunately, aware that your screen can freeze at any moment. And so faces that are transient and may get stuck. And you may get stuck in a very, in a face that you wouldn't want to look at for an hour or even for 2 minutes. So I'm more aware of what facial expressions I make, and keeping them a little bit more neutral or on the positive valence. With the older preschoolers, I'm using the whiteboard in Zoom a lot. It's interactive, they're excited by it, it's novel to them. They can help tell me what to draw for a face for who's in their family. And that's a nice way of interacting and engaging in a way that we're having we have a joint attention on something that we're doing together. So those are some of the things that I've noticed as in terms of engaging the young children. And I'll be honest, there are children who I don't have the skills yet to have engaged. And so there was one little girl, the best view I got was the back of her diaper for most of the visit. And that was just how the visit went. There are a lot of things that we do in early childhood mental health assessments, though, that are really well suited to telehealth. So we can do an interview like the working model of the child interview. We can even set up a modified parent-child interaction procedure like the Kroll and coach parents through it if they have an earbud. So those things are actually pretty exciting to be able to do in the home and protect parents from needing to drive in. We can record in many of these platforms for feedback to the families and for teaching. So those are, I think, innovations that may actually make things easier. And then the last piece, which isn't really so much about telehealth, is that all of our assessments now have to be done in the context of understanding how COVID, the pandemic, the increased focus on racial justice has affected this family and what that means to them. I think those are some of the ways that I've been thinking about adjusting the clinical care that I'm giving. And I'm sure I've been seeing in the chat box people that have some really great ideas. So thank you all for sharing those.
Yeah, absolutely. And I think you touched on a really important policy connection in talking about sort of your example from this morning of needing to, look to next week to get your observation done. And, something that we talk about a lot, even related to in-person practice, is the number of sessions that you need to be able to do a comprehensive developmentally appropriate assessment and formulate a diagnosis with young kids, and that the DC 0 to 5 recommends 3 to 5 sessions, and that states, I think, are all in different places and kind of catching up on that. We've got states piloting Z codes where you can do 6 sessions before you have a diagnosis, or some states putting 3 to 5 in for young kids, and others still only reimbursing for 1 or being able to bill for 1 before you have a diagnosis. So I think it's a policy piece that I imagine telehealth might be kind of putting a fine point on for us right now. So I know that, and I just kind of touched a little bit on DC 0 to 5, so I'm hoping we can kind of go into talking about diagnosis now. And you were a member of the international task force that developed the DC 0 to 5. I know that you have really championed developmentally appropriate diagnosis. So I'm wondering if you can tell us a little bit about what you've learned about diagnosis and diagnostic formulation via telehealth.
So I love talking about formulation. And I think that, again, the opportunities that telehealth brings to the formulation and the information that we would not get any other way really can enrich our formulation rather than limit it, which is pretty exciting. I think that I'll start with saying that I've heard some clinicians talk about not formulating a diagnosis at this point because due to when they're doing telehealth, and that they want to defer everything until they can meet a family in person. And I absolutely understand that instinct. That's our comfort zone. That's what we're used to doing. But I would push back a little bit and say every diagnostic process is an iterative process. We never, when we're working with young children, diagnoses are never in stone. They're part of a developmental trajectory, and they're not static. So we'll always need to revisit the diagnoses. And I'd really encourage people to be using information as possible to move towards a diagnostic formulation as they collect information through the telehealth process, whether it's 3 visits, 6 visits, to continue looking back as more information is available, but to commit to using the diagnostic lens and all 5 of the axes in the DC 0 to 5 nosology to really try to describe what they're seeing in a child and family's presentation. And that'll help guide our treatment approaches as well. We do expect that in the context of a pandemic, in the context of everything about the world shifting, that we'll see more families under stress. So we're going to see more children who are experiencing, I would expect, more mood disorders, more anxiety disorders, more sleep disorders, possibly developmental delays that are related to not being able to access appropriate developmental supports. So we will, I think, really want to be applying our diagnostic approaches so that we can both talk to families about the how we understand the symptoms that their child's presenting with. And I would argue we need that on the policy side too. We need to be able to say, we're seeing this many more children who are experiencing these disorders, not just they're reacting to the current situation, but they've developed clinical syndromes that are getting in the way for them and their families. That's really important information. It's the only way that policymakers are going to be interested in supporting the mental health needs of young children. Moving back to the clinical realm a little bit more, I think one of the things that I've found I probably wasn't doing early in the pandemic and back in March was thinking about, are the symptoms that I'm seeing possibly related to the direct effects of COVID? I was seeing a number of children in March. I saw 3 children under 6 that all came in with the chief complaint of hallucinations. Now I see children who have some perceptual changes every now and then, but I don't usually see 3 in a month. And looking back, I wonder, could these children have been affected by COVID? Just something that we may want to think about a little bit when we're seeing children who have unusual presentations. Is there a chance that this is an immune response? And so I just encourage people to be thinking about that, and certainly wondering if children who have new or acute onset changes may be affected by the infection. And then I think thinking about the stressors, the life changes that COVID is bringing to us. And again, I think they're COVID and our attention to racial injustice and racial justice are related, but thinking about how all of these factors are affecting families means that we need to be really looking at what in DC 0 to 5 we talk about as Axis 4, sort of how the context. So I think that those are some of the ways that I think diagnosis can be reconsidered in our telehealth world. But I'd really encourage people to see this as an opportunity rather than something that will limit our ability to make appropriate diagnoses. I will also say the child who you only see the back of their diaper, you probably want to hold off on a diagnostic formulation until you have a little bit more of an understanding. And there are children I've had to bring in person because I really didn't have a good enough sense from telehealth.
I think those are fantastic observations, and your policy commentary definitely touches on, 2 issues that my team is spending so much time thinking about right now, which is data collection and just our, that we really have such underdeveloped mechanisms for capturing infant and early childhood mental health clinical level data nationally. And so, thinking about ways to strengthen that, especially right now. And then how to communicate that effectively to policymakers in ways that they can really hear and understand. So I hope that you're encouraging lots of our clinical colleagues to be really gathering up that data and really capturing that in a way that we can all start to piece together and use in compelling ways. So when it became clear that systems were going to have to convert really rapidly over to tele, I think one of the things that I was hearing most about on the policy side was concern around the threat that this might pose to quality treatment for young children. And so a lot of concern that we weren't going to pay enough attention to that or recognize that enough, as we often have to bring extra attention to little ones. So I know that you've had the opportunity to navigate a number of different treatment approaches in this time, and I would imagine you've worked with clinicians who have navigated even more. So what are your thoughts about some of the strengths and some of the limitations of teletreatment?
So I think I'll start with really going back to the multi-axial approach, that when we start thinking about treatment, we want to think about our indicated therapies that we use specifically with children and dyads and families. And then also because of the multiple pressures and including economic pressures and childcare pressures that families are under, we also want to think about our treatment plan as really being holistic and making sure that children are connected to the kinds of services they need, and the families are connected to resources to support their access to basic needs, to food, to housing, again, to childcare being so important. So I want to put that whole context out there. And the truth is, many of those other pieces are harder to get right now. So speech therapy, for example, in the system that I work in, is ongoing, but in a number of states, the early intervention programs are doing telephone support rather than video, which means much more limited impact of some of the developmental services that we may think children need. And so it's on us as the primary clinician to think about what a child needs, and also are they going to be able to get it in this moment, and how do we track that over time? So important to know what's really there. Many of our treatments are suited well to to doing tele-interventions. What I've been doing most recently, just because of the patients that I've been seeing, is parent-child interaction therapy, or IPCIT, the internet-based PCIT, which is a perfect modality because we as the clinician aren't actually in the room anyway when we're doing PCIT. So now we're not in the building. There are some challenging moments that we would use ourselves and our relationship with the child and our physical containment strategies to support the family that we can't do by tele. But for the most part, I've been impressed with families' ability to adjust and to create a therapeutic space in their home. I've also been doing a modification of PCIT focused on anxiety and the CALM protocol, and that's been working really well also. I'm very excited about the opportunities for bringing this evidence-based kind of intensive intervention into the homes. I think that a number of other interventions also have real promise, and I'm curious if people on the call have been implementing them. Child-parent psychotherapy, I think, such a relationship-based intervention that has the capacity, I think, to work through telehealth connections. I think Circle of Security, especially the video-based, the family group approach, is a great modality to use in the telehealth world. And our team's about to get trained in attachment vitamins, which is a group model related to child-parent psychotherapy. I think all of these video-based models and group opportunities are facilitated by telehealth, and probably have great promise in the pandemic and beyond. Mm-hmm. I think that in some of the interventions so I've mentioned a lot of interventions that use the parent as the mediator of the treatment, where we really work through the caregiver to affect the life of the child, and through the relationship to affect the life of the child. Something like trauma-focused CBT that's more direct interaction with the child themselves. I think maybe a little bit more challenging because we do use ourselves and our physical selves to support a child with who's facing a moment of dysregulation. And it's harder to support emotional regulation through telehealth. I'm not saying it's not doable. I'm saying that many of us don't have those skills yet. And maybe there are people who are developing them faster than I am. Mm-hmm. I think with all of these interventions, it's also important to lay the groundwork in the same way that we lay the groundwork for how do you log on to Zoom. Lay the groundwork for what do we need to implement this intervention effectively in your home? Where does the camera need to be? Does it work if you're holding it and walking around the house? I've had some sessions where I got a great view of the ceiling. And that's probably not what we need when we're doing therapy. So we need to be able to communicate effectively and have be working with families who are able to have some flexibility in the space that they're using and in being able to accommodate the needs of the therapy. I do think that we can provide, for some children, we can provide probably as good care and effective treatment by telehealth. And then there are probably some where that's where once we're able to, coming back into the office will be more effective. I apologize, there's a helicopter landing at our hospital.
That's really, really helpful. And you touched on a ton of content. And I've been seeing like the chat kind of firing off as we've gone. So it seems like people have a lot of thoughts about some of the models that you touched on. And I look forward to hearing how attachment vitamins goes for your team. I know folks are really excited about that. So I think at this point, we wanted to make sure we had lots of time for audience questions and some back and forth. So Kate?
Yeah, there's a healthy amount of audience feedback and questions and excitement about what's being discussed. So I think that would be great to pivot to now. Awesome. One of the things, so you mentioned, Dr. Gleason, like the crawl and other dyadic observation assessments. So folks wanted to, that piqued a lot of interest. Folks wanted to kind of hear a little bit more about some of those tools and like how you would recommend like a dyadic observation protocol if and when the family is ready through the screen.
Sure. So for people who aren't familiar with the CROL, it's a structured parent-child interaction developed by Judy Kroll, I think so, up at Stony Brook. I apologize, blanked on her name. And it starts with a free play session. So just, we usually do it with specific toys. And there are puppets, there's a telephone, there are some kitchen things. So we have a structured set of toys that we prefer to use, but it's a free play session. So toys that are don't elicit aggressive themes, and that do elicit some collaboration and representational play can be great for the free play portion. That part of the observation is really there for a warm up for the family, and then also to observe what play looks like in this caregiving relationship. After the free play session, there's cleanup. That is for most kids, if the free play has been fun and a positive experience, then the cleanup is kind of a challenge. And it's an opportunity to observe how can the parent scaffold the child in moving from a preferred activity to something more challenging. I just saw someone asked, how do you spell CROL, which is, it's not said the way I would have thought. It's CROWELL. Spelled CROL that way. So we do free play, then we do cleanup, then we do bubbles, which is for most people, when I'm doing a talk, I say bubbles and you see the whole audience just start smiling. We love bubbles as human beings. And it's a way to observe shared joy when possible. And then the rest of the model, the next three steps are puzzles, which move from, or activities that are task-based and achievement-based, that move from below the child's developmental level, so easy, to something that's a little bit of a reach where they're going to need their parents' scaffolding and help to be successful. Each of those goes for a couple of minutes, and we have the parent continue it until the child completes it, or repeat it if they've completed it easily. That's a way, again, of looking at development, of looking at shared joy, at looking at scaffolding, looking at teaching and learning. And then the last part of the crawl is a formal separation, and a separation and a reunion. And so that's exactly what it sounds like. That's the part that may be a little bit more of a challenge in a home, because a separation in the home is usually no big deal. Most parents leave their child for a minute or two every so often. But those are the steps, and you can think of most of those are pretty adaptable if you work with a parent ahead of time to develop a plan. What are the toys that are going to be in free play? And then how are you going to do the cleanup? Where are the toys going to go? Do you have bubbles at home? And then what activities could you do that would be a little bit, that would be teaching and learning activities? And then finally, the separation reunion, as I said, may or may not be an attachment challenge for the child, but can be done as long as the caregiver feels safe leaving the child in the room for a moment, or three.
Yeah, is there so compared to a clinical setting, which again is not as much real life, as you point out in your opening, but also can be more controlled by the clinical team in terms of what, clearing other toys out so that the bubbles are just the thing in the middle or whatever it might be. How would you recommend kind of coaching a caregiver around that? And like if there are other family members in the home at the time, kind of walking through or whatever, how do you have as real an assessment as possible?
So I think the first you have to acknowledge it won't be perfect. And I think each day many of us are facing that moment by moment. But I think that's part of the acknowledgement. If there are other caregivers in the house and other siblings in the house, you've hit the jackpot, because you can pair those two groups of people together, and have the other adults be with the other children, so that you're not having multiple children as part of this observation. If there are caregivers who might be questioning or not sure that they think the child should be part of mental health services at all, you may want to work with the parent to think, when should this happen, and how do we explain it to them ahead of time? How do we tell the parent and the other adults in the home that we want to do it as closely to our routine as possible, because we do this all the time, and we want to be able to compare to the other however many hundreds of crawls we've done. So that's an important part, to explain the idea of a standardized approach. And then I think some families have a lot of control and flexibility over space and toys and that kind of thing, and some people don't. And so I think part of it is asking the parent to give you a little bit of a tour with the camera, so that you can decide together what spaces are available and what makes the most sense. A hallway might be the best spot in some families, because those usually have fewer distractions and things to do.
That makes so much sense. Another very logistical, but I think important thing that I think your guidance would be helpful on, especially since you've been doing this for such a long time. How would you recommend handling things like basic registration, signatures, confidentiality conversations? Would you handle them in advance with mailing? Would you have a phone conversation before the telesession? And then thinking about sensitivity with respect to, and you touched on this a bit, just others in the room that might impact what's disclosed or discussed, and sort of watching for any concerning like mental health or child abuse indicators in the home.
Yes, that's a lot. So the easier part is thinking about the paperwork and the registration. I say easy, it's not, especially for clinicians who are not office-based right now. So most of the clinicians on the team I'm in Virginia are home, and same in the Louisiana team. The clinicians are home. Here in Virginia, our admin team is still in the office, and so we are in a lucky spot there that they can send things out by mail. But in many places, sending things out by mail is really not that not possible. So we use something, and I just saw it flashed up. We use something called DocuSign for signing some documents. That seems to be a fairly easy thing for families to do, and not cost prohibitive, especially low volume. I'm pretty sure is free. I think that every agency and organization is going to have a different interpretation of the HIPAA waiver that came out saying we could use telehealth services without the usual HIPAA precautions. I defer to everyone's agency and their legal folks on what that means, but it does allow us to use. It does, I think, open some flexibility around emailing and emailing forms and that kind of thing. Someone's popping up with Adobe as a way to fill and sign as well. So I think there are a number of ways to do that, but still more challenging in some of the forms that measures that we might want to use. You either have to build yourself or send by mail. So I think that's been a challenge, and I think though is pretty locally specific. In terms of the confidentiality in the home, again, I think there's a value to acknowledging the limits of what we can know. We can't know who's in the room with absolute certainty, even if we have someone do a sweep with the camera. So we have to create a space in the beginning of an assessment and throughout a relationship to let the caregivers know that we understand that they may not be able to tell us everything right now. And for someone, if we start to see particular signs that make us worried, we may want to try to be creative about, hey, is there someone who could watch your child so we could have so we could talk about something that your child doesn't need to hear, and see if there's a way of pulling someone out of the room and creating more of a protected space. But I think acknowledging the limitations, asking permission to ask the kinds of questions that we need to ask as part of our assessment, as part of our treatment, and then giving permission to have parents say, I don't want to talk about that right now, are probably the ways that we can maximize the relationship and create space. But the more we ask people to move around the house, the more we may be able to have those opportunities to naturally hear, hey, I didn't want to say this before, but.
That's really smart, to be able to use the navigation through their home as a way to see more of it and understand that more. And as you're talking, I'm just being, I'm struck by the idea that adaptability, which is, I think, high on any infant mental health, plan, because you always plan to adjust what you wanted to do because you have to be responsive to where young kids and families are. And this idea of really being relationship focused. I mean, those are two grounding principles of infant mental health. So I think the idea of really leaning into those as strengths of our field right now makes a lot of sense. Another really interesting question that came up a little bit is if there's either a limit to video and folks are only available on phone, or if they're not comfortable with video, is this doable over the phone in any way? And what would there be indications around diagnosis or assessment over the phone?
That's a great point. And I think there are huge limits when we don't have the visual information. And that would be a time when I would be really reluctant to say that I had any confidence in a diagnosis. I think when you only hear, especially if you only hear from an adult in the relationship, you're pretty much doing a consult. And I would say that we probably want to be open to that in this moment, that we don't want to only provide services and support to people who have access to and comfort with the technology that allows telehealth. But I think we need to acknowledge that we're probably doing something different with people when we're on the phone. One of the residents at Tulane who I was supervising in the beginning of the pandemic was doing a great job of being creative with this kind of thing. And so this was with a slightly older child, a 6-year-old, I think. She was asking the child to draw as part of their telephone sessions, and then to describe what she had drawn. And obviously this child had fairly good language development and was able to do that, but it was a way of connecting, keeping things concrete and developmentally appropriate, and eliciting information about what was important to her. So she had her draw experiences of happy and experiences of other feelings. I think that was incredibly creative. I think most of us probably would be sticking more with parent support when we're using the telephone, especially when we're talking about younger children. And so would want to define our role a little bit differently. So I'm here to help you with thinking about how do you interpret your child's behavior? What are the other ways to do it? Is there anything else that could be affecting why your child is having a tantrum? So using those wondering kinds of questions, but recognizing that a infant mental health intervention that's only got access to one of the people in the dyad is not our norm, and kind of a limited scope.
Makes perfect sense. So you talked a lot about kind of engaging families in this sort of in mental health with respect to tele, but an interesting question came up in the chat about keeping families happy and motivated in sort of continuing ongoing virtual sessions. So this author found that many families are burning out with virtual sessions and they really want more in-person support, and that they may feel overwhelmed with the change. So any thoughts about how to sustain, like once tele is established, how do you sustain the family really being supported?
Yeah, that's interesting. And I'm thinking about it because I haven't been running into that quite as much. I can imagine two kinds of families, or two groups of families where that might be the case. One who has very limited other Zoom or other platform experience where this is novel each week, and a struggle to do technologically. And then the other group that I could imagine getting burnt out are the families who are already on a video platform for 8 hours a day, and then you're asking them to join yet another one. So those are the families I would imagine it might be the biggest struggle for. I think the things that we do in usual practice probably need to be emphasized and maybe even exaggerated in telehealth, which is all of the positive reinforcement for motivating to join a session, for the positive interactions we see with the child, reflecting to a caregiver how we see their child responding to their positive attention. And so so I think that part of what we do now in-person activities just has to be more, because we have to recognize that they're living through a pandemic and everything else that's happening in 2020. And then we're asking them to do something that's a little bit harder. And then if they're not hearing from us what a great job they're doing, it would be hard. And so I think there's a lot more time spent in maintaining the relationship, in acknowledging the challenges, and then acknowledging the gifts that parents are bringing to the sessions. I think that's as you asked it, those are the things that came to my mind. And then someone in the chat, I thought this was really neat, but someone said they're sending things to their family, physically sending things to their families to keep them engaged that way. And then there are people who are so isolated where each clinician is going to have their own risk-benefit analysis based on their own family, their own physical context. But there may be people who really do need to see someone in person and have a brief in-person session. If they live in a place where it's nice outside, like meeting outside the clinic, if the confidentiality feels okay. I think people may want to be creative about those families who are burning out from this mode of connecting.
Well, and actually that exact topic came up as well with respect to families and trauma symptoms, and like when do you, where do you breach the line or threshold with respect to needing to not move off of tele and actually have them see somebody?
So in our practice here, from the beginning, we've said that it's a clinical judgment. So we've had very few in-person sessions, but every session has been telehealth, because the risk-benefit analysis on the clinician's judgment And the family's judgment is that telehealth is the right way to go. So I hate the answer of it depends, but I think it depends. Personally, I think some of the factors that go into that, one, clinician's own health status, right? Like that's an important one to keep track of, and also the health status of the people in their COVID bubble, the people that they're protecting. So I think that's truthfully a huge part of the decision. Also the family's health status. Everyone's got their own level of risk tolerance in situations where there are things that are unknown and unknowable. And I encourage people to honor that. We don't have absolutes. We don't have guarantees. And so respecting that is an important part of that assessment. The way I've done it for children who I really felt, I need to see them, I'm not really getting it, I don't understand. I've brought kids in for example, as a physician, I brought kids in for a neurologic exam, which I cannot do by tele. And so spent about 15 minutes in the room with them doing that and interacting with them and getting a sense of the connection that way. And then honestly, I went into another room, the family stayed in the exam, in the playroom, and we did a telehealth while we were both in the same office. And it felt a little bit funny, and it also felt more connected than when I just do telehealth. So there are hybrid approaches that people may want to do as well. The same may go for children who were wondering about autism spectrum disorder, which I think is one of the hardest diagnostic questions to answer by tele. Yeah. So I think there's not an answer to how do you decide whether you're going to see someone in person, but it does involve the health status that we know and our assessment of the things we can't know.
Mm-hmm. And related to that, because I think this is all seems so logical, even though there's been such a span of topics covered, is how do you support staff that feel like they're burning out with this sort of the pace and, as you said, maintaining the all that's going on with respect to this year and clinical services and concern about families, but maybe not feeling as impactful through tele?
I think that's so important, and I think that probably every organization probably needs to be doing better than we are. And I'm speaking for myself as an individual, and I think we can't do too much of recognizing that everyone who's doing clinical care right now, whether they're working in an emergency room or working on telehealth for an infant and early childhood mental health, is really providing frontline services that are so necessary and so important, and that they're also living through this pandemic and living through 2020 and being aware of and feeling the effects of racial injustice and the fight for justice. So one thing I think is, as individuals, we probably need to give ourselves a lot more grace and a lot more forgiveness for all of the things that we're doing not as well as we would if life were the same as it was in February. So one is what we can do. I think that things like this are really valuable. The chance to connect with other people, the chance to talk to people, to have these chats. Our team, just by happenstance, had a training, a whole departmental training for a couple of days, and the connection in the chat box was wonderful. And so I think the more that we have opportunities to still connect, even if we're not physically in the same place, and to provide support to each other is incredibly valuable. I think calling out what we see people doing well, and also supporting people when we see them struggling and giving them the space to say, yeah, it's not reasonable to expect ourselves to perform the same number of hours, the same level of care during a pandemic that we would at other times. And it's easy to see that in someone else, and it's harder to see that for many clinician types, harder to see in ourselves.
So well said. And you bring us right to 4 o'clock. So I would just invite either you or Lindsay to have any closing remarks or thoughts you just don't think we got to yet today.
No, I think we covered it. This was wonderful. Thank you so much for inviting us to come and do this.
Absolutely. No, I think this was a really great conversation. I'm just pulling up the last slide that will introduce you or orient you guys to ongoing conversations. As Dr. Gleason said, I think this was, the beginning of something that's really important, which is for people that are doing the same work across many different geographies and time zones and different fields to be able to connect and to be able to be energized by that. And so part of what we're doing here at the Institute and through the TA network is having a lot of different conversations that cut across the different spaces. You can see all of them here, the different topics that have been discussed with respect to mental health service array positioning to support families during this now ongoing and seemingly long-term crisis that we're in with respect to COVID. And those are all available at the link below. As has been said a couple times in the chat, we will have a recording of this disseminated, and we will also support the dissemination of resources that were discussed in the chat, as well as any others that we see relevant to questions we maybe didn't have enough time to cover today. But with that, thank you all so much for your time.